Now we are coming to the next part of the chapter, and that is we have seen about pharmacodynamic effects. We have seen about which organs are getting affected. We are seeing what are the toxic effects of the general anesthetic on different organs. And now we are coming to the kinetic properties of the inhaled general anesthetics. The inhalation anesthetic, as we all know, that they are gases or the vapors, which diffuse rapidly across the pulmonary alveoli and various tissue barriers. So the depth of the anesthesia will depend upon what is the potency of your general anesthetic. As discussed earlier, potency will be determined by the MAC value. MAC is an index of the potency. The second factor is the partial pressure of the gas. Like in brain, the induction and the recovery from the anesthesia will depend upon how much is the partial pressure achieved by the general anesthetic in the brain. So when the anesthetic agent is transferring, or when there is a transfer between the lung and the brain, it depends upon various types of the tension gradients, like what is going to be a partial pressure gradient between the alveoli and blood will determine how quickly it will move from alveoli to the blood. The pressure gradient between the blood and the brain will determine how quickly it will move from the blood and brain, and vice versa. So everything is getting controlled by the pressure gradient and therefore by the partial pressure achieved. So let us understand further factors. So when you say what are the different factors affecting the effects of general anesthesia, the first factor is no doubt the partial pressure of the anesthetic in the inhaled gas or in the inspired gas. The partial pressure is directly proportional to the concentration of the general anesthetic present in that mixture which the patient has inspired. If higher is the partial pressure or higher is the inspired tension, more will be the anesthetic agent that will be transferred from the alveoli into the blood, because it will move from high pressure to the low pressure. So obviously it will move faster from alveoli into the blood if the inspired tension is high. Thus, you can increase the induction by administering those general anesthetic at a very high concentration in the beginning, not throughout, in the beginning, to have a good induction. Second factor is what is the pulmonary ventilation rate, because that will govern how quickly your anesthetic agent will be inhaled and delivered to alveoli. If there is a hyperventilation, more and more anesthetic will be delivered per minute. Whereas if there is a respiratory depression, exactly opposite effect will be there, that there will be a less hypoventilation and that there will be less amount of the anesthetic delivered per minute. Now there is also influence of the minute volume on the rate of the induction. It is greatest especially in those cases where there is a high solubility of general anesthetic in the blood. Because when a general anesthetic is highly soluble in the blood, their partial pressure takes a longer time to approach to the partial pressure in the alveoli. However, it will not affect to the terminal what is going to be the depth of anesthesia, because that will depend upon not upon the amount of anesthesia reaching to the blood, that depends upon the amount of anesthesia reaching to the brain. But no doubt it will affect the induction. The solubility of your agent will affect the induction. So I go again through this point, that rate of induction is greatest in case of the agents which have high blood solubility, because their partial pressure in the blood takes a longer time to approach the partial pressure in alveoli. To reach the equilibrium, it will take longer time, because as anesthetic move into the blood, it will be solubilized into the blood. So it will take always the pressure gradient will exist and it will pull more and more anesthesia from the lungs. I hope it is clear. The third point is alveolar exchange. Okay, fine, your anesthesia has reached to the lungs. The general anesthetic usually diffuse freely across the alveoli. And if the alveolar ventilation and perfusion rates are normal, there is no problem. But if there is a mismatch between a ventilation and a perfusion, okay, fine, the ventilation is normal, but there is something wrong, pathological changes have occurred across the alveolar wall. which is covered with a capillary network and is going to determine the rate of perfusion of the alveoli, like that happens in case of emphysema, then attainment of the equilibrium between the alveoli and the blood will be delayed. Because although the ventilation is normal, the perfusion is not normal. So rate of delivery of the anesthesia to the blood will not be normal. And because in emphysema, there are fibrous, because of the damage to the lung, the fibrous connective tissues are replacing the alveolar wall. The exchange is decreased, exchange is delayed. And they may be well perfused alveoli, not necessary sometimes, will be well ventilated. Okay, fine, we were talking about emphysema where the perfusion is getting affected, but a reverse is also possible, that the perfusion is normal, but not necessary, they are well ventilated. The blood which is draining such alveoli may sometimes carry a less amount of the anesthetic and dilutes the blood coming from the well ventilated alveoli, because there is some portion of the alveoli which may not be well ventilated. There may be some portion of the alveoli which is ventilated. The portion which is not well ventilated will receive less amount of anesthetic agent, and so the amount of the anesthesia in the blood coming from the less ventilated area will have less amount of anesthesia, whereas the blood coming from well ventilated area have a greater amount of anesthesia. But ultimately both the bloods are going to mix with each other, and gradually the amount of anesthesia, finally gradually the amount of anesthesia in the final circulation is going to get declined. So if there is a mismatch in a particular portion of the lung, ultimately it dilutes the amount of the drug reaching to the final circulation. And that delays both the induction as well as the recovery. So we were talking about the solubility of the anesthetic. Now this is the very important property in determining the induction and recovery, because it is a large amount of the anesthetic that is highly soluble in the blood, like diethyl ether, and that must dissolve before its partial pressure is raised. The rise as well as the fall in the partial pressure in the blood, and consequently the induction as well as the recovery, therefore will take place very slowly, because we know that it is going to be a highly soluble in the blood. So it has to first dissolve, and then there will be a rising in the partial pressure of the gas, and therefore this rise as well as the rising of the partial pressure and during the recovery fall in the partial pressure in the blood are going to be very slow, and therefore its induction as well as the recovery is going to be slow. Whereas we have a drug like nitrous oxide which has a low solubility in the blood, or we have a sevoflurane, desflurane, which have a low solubility in the blood. So they need not undergo solubilization into the blood before they achieve a partial pressure, because they are less soluble in the blood. They will achieve a partial pressure very quickly, partial pressure gradient will be established, and they will induce anesthesia very quickly, because they will pass from the various barriers very quickly. So then in that case, what becomes important is a blood gas partition coefficient. And this is usually given by the ratio of the concentration of the anesthetic in the blood to the concentration of the anesthetic in the gas phase at equilibrium. So I was talking about the blood gas partition coefficient, which is given by the ratio of the concentration of anesthetic in blood to that of in the gas. And once you know that, you can easily determine whether the induction is going to be quickly or it is going to be slow. Then the important one is that, okay, we have seen the solubility of our anesthetic agent in the blood, but that's not the only compartment which the general anesthetic has to reach. There is a compartment other beyond that also, and that is a tissue. So relative solubility of the anesthetic in blood and tissue will determine ultimately what is going to be its concentration in that particular tissue once the equilibrium is achieved. And it has been found that most of the general anesthetics are soluble in the lean tissues as they are soluble in the blood, but more soluble into the fatty tissues. So when anesthesia is having a high lipid solubility, for example, like halothane, it continues to first enter into the adipose tissues. It remains there for hours, and then it leaves it slowly and start moving, to our targeted area. So the concentration of this agent is always found to be higher in the white matter rather than in the gray matter. Now, if an agent is more soluble in the blood, we talk about the right now we talk about the halothane, which is more soluble into the lipoidal layer, into the tissue layer. What about the agent which are more soluble in the blood? Then their penetration in the tissue is going to be less, and then you need a more larger amount of the drug to produce the same partial pressure which you would have achieved with the use of a less water soluble agent. So the rate of attaining equilibrium in that case will be also slower with more soluble agent. And if the agent is more soluble in the blood, then you have to use a larger quantity is required to be removed from the alveoli in a given time. So you have to, alveolar partial pressure decreases, and then the driving force for the anesthetic for transfer to the blood also decreases. So then again induction and the recovery will be decreased. The next is cerebral blood flow. We talk about alveolar perfusion, now we are talking about the cerebral blood flow. The brain is highly perfused organ, and hence almost general anesthetics get quickly delivered to it. And further you can increase it by combining it with carbon dioxide, but carbon dioxide causes vasodilation, and because it causes vasodilation, it will enhance the delivery of the blood, means the cerebral blood plasma flow will increase, and therefore induction and the recovery both can be accelerated. Not only that, but carbon dioxide also stimulates respiration, and therefore it speeds up the transport of the general anesthesia from various barriers and ultimately to the brain. In a moderate amount, you can combine it with the carbon dioxide. There is another important parameter which every one of you should know is a second gas effect, or it is also called as a diffusion hypoxia. So what is a second gas effect, or what is a diffusion hypoxia? In initial part of the induction, there is a diffusion gradient from alveoli to the blood, and that is very high. And therefore, larger quantity of the anesthetics enter into the blood. But if the inhaled concentration of the anesthesia, like we talked about those inhalation anesthetics which are soluble in the blood, so they take a longer time to achieve a partial pressure, and when you are using, and then you have to use a very high concentration of the general anesthetic. So in inhaled air, if their concentration is very high, then there will be obviously a loss of the alveolar gas volume, and the gas mixture will be sucked in independent of the ventilatory exchange. So gas flow sometimes may be higher than that of the tidal volume, and this will lead to a condition called as a hypoxia. So this is significant, like suppose you are using a nitrous oxide. Since it is given at 70 to 80% concentration, you will observe such type of a phenomena, and that may sometimes leads to the condition called as a hypoxic condition. Now, what is the second gas effect? Second gas effect is a significant only with nitrous oxide, because it is given at a concentration of 7 to 80%, though it has a low water solubility, and it is given, it enters at a rate of 1 liter per minute into the blood in first few minutes, and the gas flow is, as I already said, that it is 1 liter per minute. If you compare this figure, it is higher than that of a minute volume. So if there is another potent anesthetic like halothane given along with it at the same time, it will be also delivered to the blood at the same rate at which the nitrous oxide is getting delivered. And that will be also higher than the minute volume. And as a result of which, what will happen, that halothane, although if it would have given alone, it would not have reached at the same speed. But since it is being now used along with the nitrous oxide and its delivery rate is very high, halothane will be also carried along with it, and therefore the induction of the anesthesia will take place rapidly. So nitrous oxide is affecting the rate of the induction of anesthesia of second gas, and that is a halothane gas, and therefore this effect is called as a second gas effect. The another effect is a diffusion hypoxia, which I already told you that the reverse occurs when nitrous oxide is discontinued after a prolonged anesthesia, and nitrous oxide, since have the low blood solubility, it will rapidly diffuse into the alveoli, and it will dilute the alveolar air, as a result of which partial pressure of the oxygen in the alveoli will get reduced, and because it gets reduced, it will be termed as a hypoxia. and that is happened because of the rapid diffusion of nitrous oxide from the blood into the alveoli during the recovery, and that will be termed as a diffusion hypoxia. It is not much consequence if the cardiopulmonary reserves are normal, but it may be dangerous if those cardiopulmonary reserves are low. Obviously, we can prevent it by continuing 100% oxygen inhalation for few minutes after discontinuation with nitrous oxide, rather than, just switching over the patient to air. So don't switch over the patient directly to the air after discontinuing with nitrous oxide. You have to give some 100% oxygen inhalation to the patient. The diffusion hypoxia is not very significant with other anesthetics because they are usually administered at a very low dose, around 0.2 to 4%, and they usually therefore do not dilute the alveolar air by more than 1 to 2%. It is very common with those anesthetics which are given at a very high concentration, 70 to 80%, like that of a nitrous oxide. So now, since we have understood all kinetic parameters of general anesthetic, now we have understood that there is a induction, there is a maintenance, and there is a recovery, which are the three parameters which play a very important role. Now we have to understand how we can make the induction faster. You can either use IV agents to just induce anesthesia, or if you are using a gas or volatile agent, you have to use with low fat solubility like nitrous oxide, desflurane, or use the second gas effect like combine the nitrous oxide with halothane and speed up the induction. Emergence from the anesthesia, reverse of the induction. It will again depend upon the solubility of the agent in fatty tissues. It will depend upon duration it is going to cause anesthesia. Not only that, how long it is going to reside in the brain. It will be also depend on that how quickly he will emerge. It depends upon how deep is the anesthesia induced. So emergence depend upon the depth of the anesthesia.